Hey, it's Matthew Holt, THCB gang. The special one was I was in Japan last week, so we're going to do couple of the gangs this week. I have a fine crowd with me. I will just quickly share with you the name cards of who we got, so you can figure it out. We have a couple of a regular, a returning occasional, and a new person this week. So here we are. We have lining up Michael Millenson from Health Quality Advice in Chicago, Shantanu Nundy, like Michael, an author, although he wrote a book more recently than Michael did, called Care After COVID. We had him on this gang a couple of times. He wrote that a couple of years back, and a new face, Beracah Stortvedt, who is a the principal at digital health practice at Marsh McLennan. All right, so. Gents, we are here, we are on, and we are going to be talking a bit about what's happened this week and what's happened recently. So I was in Japan, but last week I can tell you all about the advances towards interoperability of pharmacy and health data, which is slowly happening there. Actually, I can't tell you all about it. I sat through a session, which I think I understood some of, but mostly I was out eating ramen and enjoying some very, very good sushi. So while I've
Nice.
been gone, it looks like the conversation has stayed pretty much where it was around healthcare and the assassination of the United, well, assassination murder slash of Brian Thompson, United Healthcare CEO. Um, so I quickly go around. There are obviously other things that have happened this week, and obviously other things that are going on in your work life. So let's quickly go around and have a quick sort of what have you been noticing? So I'll start with you, Michael, and then we can go on to Shantanu and Baraka.
Well, what's interesting is that the murder of Brian Thompson has spurred a lot of articles, not just about the whole sociology of that, but looking at health insurance and the appropriateness of denials and the appropriateness of the care and the level of denials, what we don't know, and a lot of different other kinds of things, which is good. There was an article in the Washington Post this morning about that, about the denials, and AHIP, the trade group, basically comes out with a statement that said, we care about evidence, patients, et cetera, et cetera. I mean, just a boilerplate kind of thing. And I think that that kind of scrutiny will be good. The other side, of course, is all the political stuff where we look at all the different health appointees putatively in the Trump administration. RFK Jr. has a nice dinner with the heads of three large pharma companies, where presumably they put a small horse's head on the table and said, "Let's talk about this and what you really need to do here." And then we're going to be heads of all the health committees on the Republican side. So I think that we're on the brink of some changes, certainly in the federal policy. When it comes to health insurers and others, we shall see. These things come in waves, and to what extent will this cause any reform? And to what extent will it simply be that when all of us go to meetings, we have to go through metal detectors? So, we shall see what goes, what happens. I mean, it's a terrible thing, and hopefully it will bring some good, but it's just still pretty shocking to everyone.
Absolutely. And I think the big question we're all going to face is something going to happen as a result of this? Um, we'll definitely get into that. Shantanu, it's been a while since you've been on. Could you, before you just remind us what your role is at Accolade? You can then, and if you can do it in a sentence, you can remind us what you thought the opportunities were for changing care after COVID, which you wrote a book about. And tell us if anything actually did happen, and then give us your flavor of what you've been working on lately and what you've been thinking about.
Sure, sure. So yeah, I'm a primary care doctor in DC. I still see patients in the safety net, and I'm chief health officer at Accolade, which means I lead our clinical strategy and our outcomes. Um, yeah, care after COVID was this very simple framework that a bunch of people started calling the 3Ds, which healthcare needs to become more distributed, needs to actually meet people where they are, whether that's at work, at home, online. It needs to be digitally enabled. We need to use technology like AI to strengthen relationships and actually improve decision making. And it needs to be decentralized. We can't just go to value-based care. We actually have to move resources as well into the hands of frontline doctors and families so they can take charge of their health. And yeah, I'll pick something really different. What's new for me is after many months of homework and exploration, I actually just put in a reverse osmosis system for my house. And it's really cool because I can see like how many parts per million my water supply had, and then now after filtration, how little parts per million it has. And so I'm drinking fresher, cleaner water, and it
Wait,
feels
wait,
good.
parts per million of what, Shantanu?
We don't know. Some pollutant.
Yeah, it's a good question. I mean, I think so. I did this thing where I actually tested my water at home before I even put the device in. And so like there was things like chlorines and chloramines that I didn't know were in my water supply. In retrospect, there was always like sometimes a funny smell when I would use the dishwasher and things. And so, that was like my own attempt at making my home healthier again. And it's pretty cool. Like my younger daughter, I have two girls, 10 and 8. My 8-year-old like can tell that the water tastes better.
Wow.
And so there you have it.
So this is the RFK Jr. effect. You're making your own household healthier again. That's pretty interesting. We'll get. I mean, we'll get into that because I thought when you had osmosis going water, but I was thinking about filtration for the air and all the money that was allocated. I'm not sure spent for air filtration for schools and what have you around
Yeah.
COVID. I know it's one of those things like you're not sure what actually happened and where and when the money was spent and if anything's ever different. But yeah, super interesting. I think. There are a lot of people who are thinking about literally fluoride in the water and all this kind of stuff, and definitely going to be there's definitely a change
For me,
about
what got me was the forever chemicals, right? There's forever chemicals in our water, and this one
Uh,
actually removes the forever chemicals
really? It
in our
does.
water. It does.
Wow.
oh, well,
Wow.
that'd be true. So
And in our county,
that's
they said they're going to remove all forever chemicals 5 years from now. And I was like, well, if we all agree that this is not a good idea, why don't I just go ahead and do this right
we'll
now?
be, we'll be doing it 5 years in the future. That's essentially forever.
Right.
All right.
5 years from now, it'll still be 5 years from now.
Absolutely. It's like EMRs used to be in the 90s. Beracah, give us one line on what your day job is at Marsh McLennan, and then give us a couple lines on what you've been following because you follow stuff widely. But give us one line on what your day job is, and then
Yeah, my day job is helping digital health companies that are innovating in the healthcare ecosystem measure risk and protect themselves against it. So with insurance policies like cyber and D&O and reinsurance sometimes and other things. And so,
forever chemical risk is probably a new line.
yeah,
You can start writing.
yes.
Accolade probably hasn't bought that yet. You can probably go sell it to
Yeah, that's right.
Shantanu or his boss quickly.
Make sure we get those PFAS exclusions removed from the policy. Uh, but yeah, so that's kind of my day job. But it's interesting right now, right? There's a lot of reactions as folks in the digital health ecosystem are very intricately involved, right, in the healthcare system generally, and what the implications of kind of what's been happening are for them from a policy perspective, short term, long term, as well as, I work with a number of kind of traditional in-person provider groups as well, doing malpractice insurance and other things like it. And so just it's been interesting kind of gathering their perspectives and their take on kind of what's going on kind of at the ground level in response to what's been going on over the past couple of weeks in the space and what the short-term and long-term implications are.
Yeah, well, I mean, let's start with the obviously the still massive elephant in the room, which is the Brian Thompson United Healthcare murder. My weird thing is that it appears the guy who did it, Luigi Mangione, right? Assuming he's the right guy. There's a lot of stuff that's totally weird in this, right? So the fact that he tried to get away, but then held onto the weapon, had a backpack with the manifesto, and I mean, there are people who like do these killings and then commit suicide or basically, hand themselves over somehow. But he was trying to get away, but then didn't really, cover his tracks as carefully as he could have done, which strikes me as odd. I did say he was never on him and his mother, apparently, or maybe his grandmother or whatever, were never actually covered by them. So it doesn't sound like he has that much connection to United other than picking United. And I guess in that case, Andrew, if he was picking around a person, he's lucky. Andrew Whitty should be counting his lucky stars. He's the head of the whole thing. So that was a bit weird. But then, probably much more importantly, is that you know this outpouring of disdain and commentary about it on Saturday Night Live and in the media and I called it scorn when I was quoting the Washington Post. Just why are they receiving all this scorn and derision? But it's bordering on hatred, right? For healthcare. So I guess I'm wondering, and we had Jeff Goldsmith on this show the other week when just after it happened, and he said, "Look, the thing you got to remember is that, and you, Shantanu, you're on the front lines of this, is that healthcare workers have been incredibly vulnerable to physical attack and assault. We obviously went through the pandemic where public health officers were like having to move house and get security details and that kind of stuff as the whole question marks over science and people wanted to hang Anthony Fauci and all this sort of stuff got going during the pandemic. So we're at a sort of fever pitch point in society anyway, and this may have been the spark that turned it off, turned it on, or set it off. I guess the question is how much do we think this is just about health insurers, and how much do you think this is about the overall system? So I don't know, Shantanu, I'll come to you and ask you how you felt that, because you're touching it from the employer point of view in your day job at Accolade, obviously from the safety net point of view, and then actually the people providing care in a variety of ways over what you're touching. How much do you think this is disdain and frustration with all of healthcare, and how much do you think it's about insurance?
Yeah, I mean, I think it's a really good question. I do think on some level insurers have become a little bit of a collective scapegoat,
Yep.
right, for so many other parts of the healthcare system that I think have lost some moral direction, candidly. And I think, particularly, sometimes healthcare will say, well, we're a business and, we have to be, but then at the same time, they talk about how we save lives. And it's like, well, which of those are we? We can't, when it's convenient, say we're a business when we're making cuts. And then when we want to glorify the work we're doing, talk about how we're saving lives and we're here for patients. But I do think that insurance companies are bearing a fair bit of the brunt. And I think like Michael said, I mean, I think there is an opportunity for us to really step back from this. As to whether or not we will or not, we'll see. But to step back from this and ask ourselves, what do we really want from our healthcare system? We as like citizens, as people, as patients. And I think like they always say, every system is perfectly designed to achieve the results it gets. And I think on some level, that's what we're seeing here. It's obviously tragic. And there's a tragedy every day when we do, inappropriately deny care or we inappropriately restrict care, that has it, or give care that's unnecessary. It has a huge, toll on human health. It doesn't hit the front lines. It's not, it's like the jumbo jet that crashes every day. That's how many medical errors we make. I mean, if you think about how many people are impacted by like the misalignment in incentives, it's almost incalculable how huge that impact is. And so, I think that's what we're seeing is that frustration. And I think people really questioning at its fundamentals, like how the healthcare system should be structured.
So I've seen a couple of different versions of what this should be like. A couple of them. So there's a professor called G. Bay. I hope I pronounced the name.
Yeah, at Hopkins, I know her. I've taught her class.
I mean, who's essentially saying, well, here's what we need to do is now we expose this terrible impact of the ACA, which cemented in place these big insurers. We need to get rid of all this and go transparent, sort of, HSA only purchase pricing, the sort of the Newt Gingrich solution, as it were. That's like a minority opinion. It's hard to see. I don't see a lot of outpouring people saying, I want to get back to paying cash, right? I see a lot of people saying, well, this doesn't happen in France or Germany or Japan or wherever. And I'm probably one of those.
Or Kaiser Permanente, where they don't have.
Or Kaiser, right? Or the VA.
Yeah.
I've got some trouble with the VA. But just let me finish that one point, Michael, before you jump in. But that, as I said, that really is what you could argue in the US, that for both commercial insurance from employers and for Medicare Advantage, we've decided, and Medicaid, a lot of Medicaid, we've kind of decided to outsource those tough government decisions to these evil for-profit private sector guys. And then when they do what we kind of ask them to do or set them up to do. We don't like it. Michael, sorry, you're about to jump on me. So,
Well, I know that's fine. I know, and I agree with what Shantanu said. Particularly, every system is say is designed does what it's designed to do. I would say this though, Matthew. If only people said it's not like this in Japan or Germany or Kaiser Permanente. Unfortunately, we have set up this thing in this country where the only alternative to the current system or the kind of like get rid of third-party payment is we're going to be socialists. We're going to be Canada or we're going to be Britain. And people don't even know that there's an alternative that's called, the rest of the world. And that we do not have to give up capitalism, God help us, and become Canadians or Brits in order to do that. There are other systems. Yes, they involve government.
That is true. The reason I bring up Canada, Japan, I am just in Japan. I was talking to some people about what is the status quo in Japan about sort of getting care. I happened to go to an art exhibit with a shoulder surgeon randomly, but on Saturday. Fantastic art exhibition. If you go to Tokyo, it's called the I've now forgotten the name. I have to look it up. It's an amazing modern art display visual Met Labs, Temp Labs, Met Labs. Gone. Okay, my brain got scrambled by the flight back. But I was saying to him, he's a shoulder surgeon. I was saying, in Britain, if you have shoulder surgery because of the NHS and you need it, unless you can go the private route and pay it, and have private insurance, you may be waiting a year. I said, what's the waiting list for you in Tokyo? And he said, it's a month and a half. It might be 2 months on the outside. It's not bad, right? It's kind of what you'd expect. Now, a couple of things going on in the Japanese, German, French system. They have multiple insurers because but they all pay the same fee to the same doctors through the same system, and that fee is all set by the government. So it's essentially not very different from the government paying. They have a different sort of back end, and you may have a different membership. And so I said, well, do you have to pay bribes to go around? And he said, it's not really. There was historically an idea that you had to like bring the chicken or do whatever to get yourself up the queue, and that's not really the case in those countries. They are still spending in many cases much less, and as Uwe Reinhardt showed us nearly 30 years ago now, 20 plus years ago, that's because we get paid more, we pay more, and in general the system gets paid more over here, which is why we had to come to all these efforts to try to restrict the cost, even though we don't. So I'm not sure how not, if you look, scratch your hard. Yes, if in Britain and Scandinavia, where most of the doctors and hospitals work for the government, I mean, you could argue that's a different system. Everywhere else, where it's kind of a fee-for-service system, but the fees are extremely limited and set by the government and what they pay for. It kind of looks like Medicare to me. We have public hospitals here. We have the VA. We have county hospitals. We have safety net clinics like the one that Shantanu works at, which are, maybe not government owned, but might as well be. I mean, in some cases they are. So I struggle as to whether there's how different these systems are. It's just we have this multiple different variation of costs. Different patients come with different ability to pay on their heads, and and that's why HCA has lots of hospitals in nice, wealthy suburbs and not many in sort of poor inner city areas.
Well, let me pose a question to the group that I've been struggling with as I think about the insurers. So there was a report of some of the Medicare Advantage plans have had real problems with their earnings, as you all know, because it turns out when you enroll a lot of people and they stay with you, they get older and sicker, and they've spent more money than they planned. And I thought of an analogy to the big betting sites, which you might have seen that FanDuels and those guys had a really bad earnings quarter because it turns out that all the favorites won. And therefore, the people who are betting with the favorite odds won, and therefore their earnings went down, right? And I started to see an analogy between the betting sites and the Medicare Advantage plans. That I'm betting that you remain healthy, but sometimes the odds line up, and it doesn't happen. And I'm wondering, if you're in the health insurance business, which we changed from sort of the mutual model to what we have now with so many large for-profit companies, how do you guarantee Wall Street quarter to quarter earnings increases because in your core business, which is insuring people, there's this huge element that you can't control. And if you're a mutual or you're a nonprofit in some ways, you can have ups and downs, and that's sort of expected. And you have reserves. But if you have to drive earnings ever higher and you can't control whether people get sick, yeah, you have ancillary products or whatever. How do you do that? And that really is the kind of root of what we're talking about, even with well-intentioned people. So I'd be interested what the group thinks about if you're trying to get quarterly earnings every quarter to go up and you're in an insurance business. How do you do this while being wonderfully benign to all your members?
I think that's a classic problem, right? A classic challenge. And I think there's different ways that I think Medicare Advantage plans are trying to do it with, having risk-bearing organizations take on some of the risk from the population, right?
Yes.
That may have control
Right,
over the
right.
actual provision of care and think they can move the lever on what those results actually look like, or other solutions like that, where they're like, all right, well, how can I get in there and actually try to figure out a way to align
Right.
incentives to make control? So that's one avenue. But the other is, I think it really is like pray, like throw the number up and pray and just say that I can do this, without any real backing. I mean, I've seen a number where it's like, oh yeah, we have these great programs that drive better outcomes, but there's really absolutely nothing behind it, because they're not actively aligning incentives to control what they even can control. And that's where some of the problems come into play, I think.
I completely agree with Beracah on that one, and I've done a little bit. I've written a couple articles about the the reports that Humana puts out regarding its Medicare Advantage population. Only about a third of its Medicare Advantage population are what I would call any kind of devolved capitation risk, and they say, and I've written this report a couple of times now. They say that that in their numbers, the difference in cost between the group who go to devolved capitation and the rest of them who are in fee for service light is actually very, very minimal, which tells me either they can't control capitation very well, or they or they have really good controls over fee for service. Now, if you look at what their results have been, their corporate results, turns out that especially post COVID, I think it was to say what was the result of COVID. It wasn't necessarily what we got out of Care After COVID, that rather fine book about the 3Ds. It was a lot of delayed care because the elective care didn't happen, and then in a few quarters, especially at the end of last year, you saw dramatic increases in utilization, and it seems to me that there was very little quote unquote control of what was going on from the health plans, which strikes me as a couple of things, which is one is, well, what have they been doing all these times in systems and money that we've been thinking about? If they can't manage the risk in their population health, what were they doing? Which is a general question. And the second one is that if we're paying them to do that, if the government and others are paying them to do that, and they, by the way, are making a lot of profit, forget the sort of profit versus being good people balance. Kind of what are we getting for our money? Now, the other thing is, okay, if you say, well, we're paying them to do that, are they still coming in under or better than the cost of Medicare fee for service and the cost of other unmanaged care? And I think they always used to. And there is, within the Medicare Advantage policy wonk literature, there's a big dispute between the people who say that, particularly MedPAC on the one hand, and Rick Gilfillan and Don Berwick saying, oh, it's way more expensive, and there's, Medicare Advantage costs us money, and some of the other side, certainly George Halverson and a bunch of other, sort of people looking at some of the data from the Medicare trustees say, oh no, they're getting a capitation payment that's lower overall, and it's saving money for Medicare, and no one seems to be able to tell me the real outcome of that. But it still seems to me is that we're not clear what we are paying, why we are funding these large, predominantly for-profit organizations on Medicare Advantage and elsewhere, why we are funding them so much to manage this system, and whether we're getting anything out of it. And that to me is the question that's bubbling up with all the hate and opprobrium about denial of care and all the rest of it. Because I promise you, there's denial of care in Canada and England and Japan and elsewhere. I think so. Or at least takes care at such a low price that you may not get it unless they're just all much healthier than we are, which I kind of doubt. Shantanu, tell me, what do you think I mean, to sort of riff on that, where do you think the employers are? When you guys go as Accolade and say, hey, we can deliver, primary care and we can manage specialty referrals and we can do all the great advocacy, the sort of patient advocacy work, that's in the name of the company. uh, what are you sensing from the employers about what their feelings about working with health plans and ASOs and all the rest of it?
Yeah, I mean, look, I mean, I think they've sophisticated enough to know that there's a role that they play. I think the question that they're asking themselves is what role should that be? Right? Like I think when we roll out our full Accolade model, the carrier is basically doing claims processing and network configuration, right? And we are sort of taking on anything that touches a member patient, as well as adding, like you said, virtual primary care and second opinion services. And I think that's really the direction that I see more and more employers interested in. And I think you're seeing the carriers start to replicate some of those and say, well, we do navigation too, and we do those things too. But fortunately, our segment is mature enough now where the employer will say, well, okay, well, then show me the outcome then, right? Because we get this much engagement, this much satisfaction, and this much ROI. And that's a really difficult thing to be able to just demo and say that you can do, right? And so that's really what we're seeing. The other thing that we're seeing sort of trend wise is we're seeing employers start to, I think, simplify and consolidate their partners as well, right? I think we had a little bit of, I like to call it like the irrational exuberance of the last wave of where there was a point solution for this and a point solution for that. And we're seeing that proliferation really change. And there's a high bar for outcomes, but there's also just value to say we just need fewer things. And even though healthcare will continue to have its cost and other issues du jour, whether it's GLP-1s or cancer or something, ultimately you need a fairly broad-based approach in order to address it. And so I think employers are starting to recognize that too. So those are the two things. It's really the limitations, of what a carrier can do, and but also the value of the core of what they do, as well as recognizing that they need less solutions ultimately, and the ones that deliver value.
So if you're going to go to an employer saying we're doing all these different things, at what point does the sort of does Accolade take you on the shopping block as opposed to the insurer? Right now, I mean, I think a lot of these either point solutions or digital health solutions, maybe Beracah's selling insurance for this, are kind of flying under the radar, providing a bunch of services which look like providers, and it's probably not recognized what their relationship is with the health plan or with the employer by the average person using them, or who's hearing about them. But more and more people are getting ad hoc physical therapy from a Hinge, or primary care from a player like Accolade or whomever. There are decisions made there, right, about what you can and can't get. Now, most traditional, what you're hearing a lot of, every day on my YouTube feed now is most traditional, you know, you see oncologists saying United Healthcare demands that I, get a prior authorization for this chemotherapy, and meanwhile the patient died, or that kind of stuff. You're hearing a lot of that about that. Do you think that the bad guy blame that's going to the insurers is going to get distributed more around the system, especially given what employers are paying for?
Um, that's a big question. It's a big question.
Well,
Uh, I mean, I
are
am
we organizing bodyguards for you and Raj yet? I don't want to joke,
I am
darling, but that's kind of where we're going.
I, I do feel like ultimately people need to trust, like, healthcare is built on trust and people need to push that trust somewhere. And I do think that there is a little bit of a reversion of that trust coming back to individual doctors and nurses and clinics. I think sort of the big corporate, insurance company or the big corporate health system, that's I think is what's in the crosshairs. And I'll tell you, like personally, like I just had, and he's fine, so I can end with that. But my dad just had a massive subdural hemorrhage, meaning a bleed between his scalp and his head and his brain. And the care he got, now someone who's been in healthcare quality and safety and has criticized the healthcare system as much as I've used it. he had an amazing care experience, like just amazing, right? Like every doctor, every nurse, every occupational therapist that came to see him just did such an amazing job. And so I think that's important because I think that's for most people when they tell me that they're actually in front of their doctor, in front of their nurse or whoever pharmacist, they have a good experience. And they are usually impressed and sort of walk away with more trust in that person. I think the distrust is more in the system, right? And I think that's where, I mean, I think the reason why Ackley works, I think, so well is because I think that we're trying to we're not disintermediating those layers, but we're sort of removing those layers and just helping people get from that one care experience to another and not sort of fall down between the cracks.
So,
in your book,
Shantanu,
let me just interrupt 1 second, Michael. Just in your book, there was a great example of one of the Accolade and on the phone nurse navigators helping somebody through I think it was a suicide attempt or something pretty similar to that, really intense piece where that person was kind of the glue and the link between all the different systems and help that the patient needed. And, that's an area where there's a lot of frustration, obviously, in the current system. People don't have access to kind of that trusted guide through the
Yeah.
system. And maybe you're kind of coming on this, Michael, but I'm still back to the point where, you know, right now, a lot of stuff that happens with providers can turn around and say, well, I want to get you this, but the insurance company won't let you do it because they're insisting you go through step therapy or whatever it happens to be.
Sure.
And, you read a lot of cases where it's like, we know they're going to end up in the more expensive therapy, and this is just perfunctory denial or it's the AI denial or whatever. But there are clearly other cases where we do too much of stuff and there's bad care going on. I mean, both you and Michael have written extensively about the safety issue and the overuse and all that kind of stuff. We know that's going on, and we've got to figure out some way of pinpointing that in the system. Sorry, Michael, I interrupted you. I don't think you were going to go down that
yeah,
path.
so I agree with Shantanu. So yeah, I think the trusted navigator stuff is great, and certainly when people get good care from the clinicians, there's a couple of things I struggle with. So first of all, most people don't understand that their employer has clout with the insurer and can help them, right?
Sure.
So during COVID, I was talking to a woman in Minnesota who had long COVID. Early on, it wasn't recognized. She went to her health system, and even though, of course, everybody in Minnesota is nice, the advocate for her is really an employee of the health system, right? And she was running out of her disability days, her vacation days, and her husband didn't work, and she was like really in bad shape. I said, well, who do you work for? Well, I work for the state of Minnesota. So, well, they're the customer of, the health system. And she called the HR person, and she got all within the day. The health system called her back. They got the letter she needed for referral and all the rest of that. So people don't understand, first of all, that their employer has made some of the choices that they may or may not like.
Right.
And when the health plans are criticized, it would be rather foolish for them to go, "Hey, it's not us; it's our customers." That isn't going to happen, and so people don't understand about the employer. The second thing is, and you know this really well, is while the sins of the insurers are very visible, the sins of the healthcare system are not. And the thing that people like you and I struggle with is good people who in the one-on-one, the doc who's going to stay up all night to help the individual patient, but approves the budget that won't include infection control, right?
Right.
The hospital that gives, your dad great care. And yet there's an article by the researchers from Harvard, David Bates's shop, about fall prevention, trying to make the ROI on fall prevention and having to tell hospitals, you know what, you can have a fall prevention a program for 88 cents a bed, even though it's a non-reimbursable event. Right. And it's all in academic literature, so nobody sees that kind of thing. Nobody sees, like you and I do, the non-evil people making evil decisions.
Right.
And so appropriateness, right? So my brother-in-law once they thought he had a heart issue, right? He goes to one doctor who recommends stents. I said, well, I don't know. And I sent him to another doctor who's an academic doc, and she says, no, you don't really need it. Well, the guy who recommended stents was a former military surgeon, and all the rest of it. I'm going to go, right? Eventually, he didn't need it. But when your doctor is sincere, there's not a little red light that goes on that says, I make a 20% profit margin off the stent, or I'm
Right.
giving you extra oncology drugs because, there's right. So we don't know. And they are sincere. And that's the problem we struggle with. Whereas no matter how sincere Andrew Whitty is,
Yeah.
underneath is I'm even more sincere about quarter to quarter earnings,
Yeah.
right? And so that's what I struggle with,
Yeah.
and I think Accolade does a great job, but
Yeah.
the bad actions don't come from identifiable bad guys, as it were.
Yeah. Yeah. And well, look, we don't have to solve everybody. I mean, so I totally agree with everything you're saying. I mean, there's a couple things that I think we do that I've had a hand in that I think are trying to address that problem. Well, number one is, you said the word appropriateness. Like we now have data that says we can look at every doctor on a Gaussian distribution and say, this doctor is doing 5 times the stent rate as everybody else. And we've gone, through the partner that we have, we've gone to the American, College of Cardiology and said, is this past the cutoff or not? And if so, we don't guide people to that doctor. Now, that's on a population basis. He could still mess up with just you or your family. But the second part of it is for things that are above a certain threshold, what we're saying is let's have you get an expert medical opinion. Let's have you meet one of the country's experts on the other side of the country who can just double check that this is the right thing for you. And it's a great experience. You get to spend 45 minutes talking to this Uber expert, but a lot of times we find that Uber expert makes a small change or a big change to your plan. And other times they just say this plan looks great and it's reassuring to them. So that's kind of my view is how do we stitch together,
Right,
a
right,
set of tools that I think
right.
are potentially better than the current alternative, which I think is, like as we're all saying, is an incredibly blunt instrument.
So how many
Um,
people are you serving, Shantanu? How many patients do you guys serve?
yeah, so all in, it's 14 million today.
Okay, decent.
But 5% of the population. I'm always back saying if you add up Accolade included and
Yeah. Yes.
Forum, all the rest of them together, you
We have
still
a
don't
long way to
you
go.
still don't get to any big chunk of the population. And Beracah, you look like you're about to dive in here, but there was kind of a question there about the point solutions versus the overall piece and the role of the people you serve with digital health companies. And I was kind
Yep.
of kidding about, was it plastics insurance or whatever, but for I don't know what is coming out of the stuff that you're selling to them, in terms of the insurance coverage side, but what do you see as the role of all these different smaller companies when you have the bigger point solution, sorry, the bigger comprehensive solutions like the accolades and actually the things that Optum are trying to put stitch together? How do you think that's playing out in the way employers are thinking about it?
Well, I agree completely with Shantanu that we've seen a trend over the last 3 years for sure of moving away from hundreds of individual point solutions to multi-provider partnerships. So we're seeing a lot more trend toward, former point solutions creating partnerships for contracting with multiple potential customers to try and solve some of that administrative pain for employers because nobody wants to deal with vetting 500 point solutions for anything. So that's absolutely something that we're continuing to see. But I think these point solutions, they create, and if they're able to do it well, they create a system of doing what they do in that point solution really, really well in a way that when it's stitched together appropriately can make a dent in the things that Shantanu is talking about, right? In terms of that collaborative framework that's going to handle, we have a solution to handle driving down costs in this particular condition or this particular, you know, issue in a population. And if you can move the needle on all those individually, collectively, you can move the needle in a direction that handles some of those sins, unintentional or intentional, that Michael was kind of referring to, right? Like, and sometimes it's well-intentioned people that make bad decisions because they are, the incentives in the system aren't there. And I think one of the things that I want to point out too is a lot of my digital health clients are smaller employers themselves. And it's one thing when we talk about large employers, right, who have a lot more control over
Sure.
self-funding and managing a lot of these other things. But when you're a small employer who has to buy a fully funded health insurance plan, you really don't have a whole lot of you don't have a lot of control. You don't have a lot of influence like Michael was saying earlier, in terms of getting that individual, employee that assistance. His point is great. When you're a larger employer, you absolutely do, and people don't know
Right.
that they have those resources, but a small employer doesn't. And I think that's where a lot of the disillusionment, and I'll say, I think this is a broader societal trend, not limited to healthcare, right? Where we see this pattern of, um, the system is against me. The system is against, my development. Not just in healthcare, we see it not just in the US, right? We see it globally. We see those trends happening. And I think it's just manifesting itself in healthcare in the way that, over the past couple of weeks has started to come to light. And I think, um, it is hopefully in the long term, it can lead to change, but even as we've talked today, right? It's so multifaceted and the system is so complex that there's no way this thing is going to be, we can come to a fix that's going to be immediate. But I think I love things like Shantanu is doing, and others, to try and help people navigate the system more appropriately to get what they need to get out of it, to restore some of that trust, because that's the big problem, is widespread distrust in the system, healthcare or otherwise, that must be solved for in some way, shape, or form.
So let's go to the question you raised there, right? What's the fix? And I want to go to, and I want you guys to, I was going to write this up and I didn't have enough to say, or I thought I'd wait till you guys told me the answer so I can claim your ideas for my own. So we're in a really odd moment for this to happen, right? Because we are a month and change away from a new government.
Sure.
We have a new set of leaders who have to come in and be confirmed. We have no discussion at all in the campaign. Tiny bit of discussion from the Democratic side about, price controls for drugs and what have you. And we have some stuff hanging over from the ACA. But this was not about healthcare the way that 2008 or something
Right.
like that was, right? So now this thing's happened. Clearly, there's a ton of angst that's been revealed and whatever, and you would expect under regular circumstances, this was in the middle of a typical, early on in the congressional or presidential term, you'd expect something to be seized on this and people to start introducing bills and what have you. But because of where we are, and uncertainty what's going to happen, who knows what is going to be introduced. So, do you think that there is enough interest on the sort of Republican populist Trump side to introduce some legislation here? And what the hell would it be? Does anyone have any? I mean, or is this just gonna? There's this underlying rage, and it's just gonna sit there and not produce a relatively immediate political result. Who has a thought?
Yeah, I mean, well, maybe I can start. I don't have a lot of insight into what they are and are not going to do, but I do think that, to me, there's like three buckets of stuff, right? I think one is, people like to talk about how healthcare is a sick care system and not a healthcare system. One level is we just need a better functioning sick care system. Like, it's okay to have a sick care system. My dad was really sick a couple weeks ago and needed some help. So I think, like, there's a bucket of stuff, and I think that's the one that I'm the least clear on what it is I think they're going to do. And there's clearly a ton of opportunities. Like you said, pricing for drugs is one thing, but there's a ton of PBMs. There's a ton of stuff in there that obviously has been intimated about recently. Price transparency, which was largely started during the Trump presidency, et cetera. So, but that's a whole bucket of stuff. I think the second one is the whole idea of a health system, healthcare system, right? I think ultimately, when you look at almost any projection of where we're going to be in 2030, even, it's completely inundated by the fact that it's this tsunami, right, of the disease of despair, obesity, et cetera, et cetera, et cetera, mental health. And so if we don't start to left shift the distribution, like, it doesn't matter how well we've optimized the sick care system, we ain't going to be able to make a difference here. And even though I think people make the mistake of conflating primary care and prevention, primary care, as someone who practices primary care, doesn't do a whole lot of prevention in, like, the true prevention side of things. We do early screening and detection, which is a form of prevention, but not true primordial prevention. And I think, again, it remains to be seen what they do, but I think things like attacking the food supply, I mean, it's kind of like the price is stupid is the sick care system. The healthcare system, it's nutrition stupid. People have been stressed all through human history. We've been running away from dinosaurs and stuff. we now have a different kind of we have stress as well now, but I think what's really different is the food supply, and I think that makes a ton of sense. And then the third is
Just to interrupt you
AI.
once, we don't have a lot of creationists on the THCB gang who believe that dinosaurs and humans live at the same time, but good to see you're in that camp. So go to your third point.
And the third is AI. I mean, we can't spend an hour talking about healthcare and not say AI. And I think when I spend
We were
time
so
looking
close. We were so close.
I know, right? But but it's like, as someone who studied engineering at MIT and has been working in healthcare area for a while, it I think the thing that I think is really misguided about some of the current policy we have is it seems to compare AI or whatever to somebody who has a primary care physician who went to a top 10 medical school and knows you and your family the last 30 years. And everything is compared to that. And it's really deep. That principle is really deep in all this. And what I'm saying is, look, the reality is 40% of Americans don't have a primary care doctor. And another 10 or 15% have literally no access to care. And we have to start thinking about AI vis-a-vis nothing, not next to like, Marcus Welby. And so I think that I think there's an opportunity, and again, we're hearing different pieces of it, right? There's an AI czar in the White House, there's, the Silicon Valley push, et cetera. But I do think there's a massive opportunity to open up AI. I mean, imagine a world where like we just saw this in Michigan, but where Priority Health System partnered with Cure AI to provide basic primary care for all the uninsured of Michigan. I mean, we can do those things and we can argue about bias, we can argue about accuracy, but when the alternative is no care, like versus perfect care, I think we have to really ask ourselves, what are we accomplishing?
Yeah, I agree on that. I mean, it's somewhat similar to the argument about self-driving cars. Are they dangerous? Are they not dangerous? The question is, are they more or less dangerous? Me falling asleep when I'm driving on my 4-hour drive up to the mountains on the weekend. Somehow I
Right?
haven't crashed, but every time I drive over there, I feel kind of snoozy and
Right. Or people that are drunk driving,
or
or
drunk.
people
Yeah,
that have
or the above, right?
disabilities that prevent them from driving, or people who, right, who can't afford car. I mean, there's a whole
Yeah,
bunch of people that are excluded from that world, all for the sake of making that world somewhat perfect,
yeah.
you know, and not recognizing where they are.
Yeah, we got into a bizarre conversation which was on that note in Japan on the startup contest because there was a company which had it was checking out the toilet by whether did somebody have a UTI, did somebody have some bowel problem using only a camera. They were saying, well, the video is good enough, and the judges were saying, don't you need to have a chemical thing? It's a bit like Tesla just uses only the camera, but Waymo has like camera and radar as well. Which one works the best? I think you're right. So let me put Beracah and Michael a bit more on the spot. I mean, are we going to get some kind of legislation around the insurance part, the part that's getting the complaint about? I think you can argue that there is with Kennedy coming along, and we might have a go at the food system, and that you could argue there are things we can have a go at. They're all going to be really difficult, right? I mean, changing the American food system it's been there for 60 years and plus, and it's
Mhm.
a long effort to change it. And wouldn't it be great? But people in the end love their pizzas and chocolate chip cookies and milkshakes, and it's going to be tough. But what about the stuff people are complaining about right now? Do you think there's going to be some thing coming along that bans prior auth or bans levels of profit on health insurance, or I don't know what do you see coming out of the kind of current anger mess? You're shaking your head, Baraka. So what do you think's going to happen? It's the answer
I, um,
we can put up with
to
nothing.
be frank, not much,
Yeah,
I think. But and I think some of it's the dynamics of the political system right now, right? Like a narrow majority, you have, not really wanting to mess with capitalistic, approaches to anything. So I think, there's some limitations on what, things may be brought forth, but in terms of what is actually going to happen, I think it's going to be very difficult to do anything on very significant things. The food system you mentioned, there may be some things around PBM issues specifically, just because of a lot of the things that have happened there. Um, but other than those two things, I find it hard to believe that we're going to have meaningful legislative change that'll happen. And maybe that's my cynicism. I'll let Michael tell you otherwise.
I agree with you completely. I think that some legislation might be introduced because it doesn't cost anything and you get to tell your constituents that you introduced legislation. Then it has to get a hearing, which then the chairman of the different committees have to decide, do I want to give this thing oxygen? And then et cetera, et cetera. So I agree. The only slight modification I would say is depending on how long the fur lasts, it's possible that there will be some new regulations. Because remember, every year we have a cycle of regulation, and therefore that's the opportunity to throw in something and take credit for it. So certainly, the next cycle of Medicare Advantage regulation, whoever's there can throw in some reg and take credit for responding to populist anger. So that's fine, and the industry will influence what that is, and they'll complain like, please don't throw me in that briar patch, how terrible it is, and it'll be fine. I also, Shantanu, when you were talking about the comparison to perfect, I did some research with Hardeep Singh in Houston about direct-to-consumer diagnostic apps, about the evidence base. And what was amusing was, first of all, there weren't very many studies. And second of all, most of the studies were doctors saying, is this app as smart as I am? No, it's not. And A, they weren't really that well designed, and B, that's not the question. And you see this with AI also, right? It's exactly what you're talking about, Shantanu, is the AI smart enough to replace me? Well, that's not necessarily the question, although there's some of you I would like to replace, but that's not necessarily the question. And it reminds me, you all may know what this, oh no, I'm blanking, the guy from Harvard who was the informatics, who said any doctor who can be replaced by a computer should be, right? I mean, and that's kind of what it is. And in doing the research for my book back in the 1970s, doctors were scared that CBCs, complete blood counts done by computerized, that's awful. How can they, right? And so, doctors act like any other guild, right? How can anybody replace my handcrafted medicine? And yeah, maybe on some things and maybe not on other things. And so when you say there's good enough people don't have the access, and we see, but I see political action unless there's something else, which there could be, right? Because now, I mean, remember, before this happened, the Wall Street Journal did this great story about how all these people who are Medicare Advantage left as soon as they got really sick. And the last year of life, they went to Medicare fee-for-service, and it cost the government tens and hundreds of millions of dollars. So when you start to look at things like that, and when you start to look at some of the other exposés on algorithms and everything, much of this, by the way, which is linked to United Health, those are things which not only affect people's lives, they affect money. They affect the budget, right? And so if you're Congress or the administration and you want to dole out tax cuts or you want to give money to whatever your favorite project is, saving lives that actually save some money that you can give out somewhere, that's really attractive. So that's kind of where I see. That's not cynicism, Beracah, it's realism.
Well, I'd say that that's interesting. The stuff you're hearing the most complaining about, right, is clearly prior authorization and then, and claim denial. So
Right.
it's
And that's,
hard,
yeah, I agree with you.
it's
That's
hard
fine.
to
Right.
see. So if I produce, and there's this whole thing about PBM. So the PBM thing I think is interesting because both Republicans and Democrats, everyone's got a sense that these guys make a ton of money unnecessarily, and nobody understands how. There's no quite understanding of how to attack them, and it's this
Rebates.
mysterious business that's not
Rebates,
well
rebates.
understood. But sorry, Beracah, go on.
Rebates.
Right.
Yeah, you
So,
could say
so
that,
well,
but
let me ask you a
there's
question
a
about
lot
that.
of
I got to ask a question on that, right? Because I agree with you. It's rebates, right? So here's the thing. I'm trying to figure out, like, if GoodRx actually has a cheaper price for a drug than the benefits plan of when my daughter worked for Accenture, for God's sakes, and other things, what value are the PBMs adding other than theoretically, I know what value they're adding, but what value are they adding? I'm
You
trying
should
to
be in a
figure that
congressional
out.
committee, Michael.
This
Because
is
they
no,
don't,
this is a
they
great
actually
question
specialists don't
because I
understand
think
you.
it's the classic problem, right? And I think, I work with some people in that world that are trying to transform it, but it's typically a very old school, manual, processed industry that questionably, yes, like, right? Or is there any added value there? What is happening? And the value only comes in when you can do something like GoodRx or better, right? In terms of really understanding and creating the formularies that maximize value for patients and for the employers, right? But um, I would say if you look at the way a lot of PBMs historically have been run, they are poorly run manual businesses that have just figured out a way to make a lot of money, and that's come to light in this
I mean,
over the last couple of
And
I
years.
is it
agree.
the employer's fault? Is it the employer's fault that this has happened, that they haven't had
I,
enough of an oversight?
I'd say it's the employer's fault because they haven't questioned it and they haven't done enough oversight as well. But also, it is a confusing thing. It's back to what Michael Lewis says about the
Oh,
derivatives.
right, right.
If you can make it confusing enough that you can't understand it, you can get away with a lot of stuff. And I think you talk to folks like AJ Lacoino at Capital RX, who's been banging on about this stuff. I think identified. He said there are 22 different payment schemes the way that PBMs get paid, and most people don't recognize any of them. And I think there's enough feeling now that yes, those PBMs have been doing something dodgy. We're not quite sure what it is, that we're going to try to do something about it in Congress. And that, don't forget, goes to the big three PBMs. They're all owned by the big insurance companies. Or so I think. Well, I don't know, but if you go back to the other stuff, right? Go back to claims denial and prior auth. Yes, we've all heard about claims denial by United for people in nursing homes and getting rehab after they've been discharged from hospital. This kind of stuff that sounds pretty cruel. But it's presumably that stuff, that claims denial, that prior auth demand, all the rest of it, is designed to save money, right? It's to stop people getting to more expensive treatment. It's to stop people getting to more expensive drugs straight away, all the rest of it. There may be a lot of human suffering on the way, but isn't the idea that it saves money for the end employer, for the taxpayer, right? And I don't know if you can. I mean, you can probably do something about stopping people shifting from Medicare Advantage to Medicare for the last year of life, which is very expensive, and do something about trying to cut some of that sort of game playing. But the hardcore piece of saying you're not going to do prior auth, you're not going to do claims denial, you're just going to pay everything, you're just going to authorize everything on the first time, gets you to a situation that's been abused for 50 years plus. So I struggle with what you would actually do unless you go the hardcore way and say we're going to become Germany. We're going to have a bunch of real non-profit insurers who don't make any money, they're mutual funds, who get controlled extensively and regulated like utility by the government. And that's what sorry Cigna, sorry United, sorry Blue Cross, you're not going to behave the way you behaved anymore. I don't see the political appetite to do that. And I don't see what doing anything else makes any difference. So I'm with you on the lack of change. But on the other hand, you get this level of angst and anger. And if it keeps going, somebody's going to do
This may
something, I would
not,
assume.
yeah, this may not be the end, right? Like,
Yes, I know.
unfortunately, yeah. Um, I agree with you completely from that perspective. So,
All right. Well, we're coming sort of towards the end of our hour here, and I think it's worth us. We should just quickly go around the horn here and say, what level of interesting thing do we think is going to? I mean, we've talked about the politics of the United Healthcare assassination. We talked about various things that employers are doing, digital health are doing. What else are you looking at that perhaps we haven't talked about in the last hour that you think is going to be a big thing next year, if we're in the sort of or it's going to start bubbling up with the sense of predictions? And it could be one of these things we talked about, but is there anything new and different you're interested in looking into? So why don't I start with you, Michael?
I want to say whether chatbots should get polio vaccine, but
You should ask a chatbot when
actually,
they're going to get it.
actually, I think that, politics are going to come to a fore, right? I mean, the managed care thing may or may not percolate. There's a lot of other things going on in the world that can take attention away from this that have to do with, the Middle East, inflation, a lot of other things. But I think that we will start to see the views of the people who are going to control healthcare policy are going to take a lot more of the attention. And I do think, AI, obviously, we see articles about everything to do with AI for all sorts of applications. But I really do think that some of the healthcare kinds of applications are going to start to come to the forefront, not in the next few weeks, but certainly as we advance. And that's a challenge. I mean, it's a challenge to the healthcare industry to deal with both economic issues, political issues, and oh my God, technology that doesn't take 10 years to implement or 20 years to implement. So I think it'll be a challenging time, which will be good for the healthcare blog gang.
All right, so I'm glad that punditry and commentary is going to have something to talk about. Beracah, what are you looking at? What do you think?
I agree. I think particularly generative AI solutions in healthcare, as Shantanu brought up something, earlier about that, about AI generally and its applications. But I think generative AI solutions and their effectiveness or lack thereof in healthcare is going to be a big topic in 2025. As I think, looking at more traditional machine learning solutions versus generative AI solutions and kind of how that's all going to work and what it's going to do in the healthcare system. I think that'll be probably the biggest trend, non-political trend, I would say, in 2025.
There may be some politics of it as well, right? If you think about,
Yes.
I mean, if you think about what I saw just, in Japan recently, I've seen these demos of essentially nurse replacements. Now, I understand that, Shantanu's point is dead right. A lot of people haven't got access to this, so AI is better than nothing. But again, it's always the politics of this. Is this replacing my job? Is this taking it? I mean, we've seen some complaints about that stuff already from the unionized nurses and some back and forth with doctors, and the rest of it. And I wonder that's the thing where the weight of the influence of healthcare providers is pretty strong. You're hearing them a lot about insurance denials at the moment, and a lot of this stuff about United has been driven by complaints by providers. I see, YouTube is now in my feed just throwing me complaints and complaints and complaints. And a lot of it is, is they've been gone off and interviewed doctors and they're talking about the denials of care. It may not take too long before they start interviewing doctors about this terrible AI thing that made my decision change or put, or somehow got between me and you as a patient, and it's going to have to be brought in very tactfully by the technology people who are going to be doing it. And, they haven't always done this the most skillfully in the past. But I agree the potential is enormous. And I'm a huge fan of it, especially in areas like mental health and customer service. I just think, it's not coming into making, a good system quite a bit better. It's coming into a very broken system that has not done well with customer service and doesn't have a good reputation. So it doesn't necessarily mean it's going to come in and fix it all, make it better,
Yeah.
even though it could. Yeah.
And potentially the shortages of the people who can actually do the things to meet those needs, will dampen some of that,
You might
negative
hope so.
feedback too, because there's like, well, my job's safe. There's so much of a shortage for what I'm
Yeah.
doing anyway. I'm not worried about it today.
But
So that you may see it be delayed till it gets to a level where it does actually start to threaten existing provider jobs. But I think there's so much, like Shantanu said, the alternative is nothing. So
yeah.
when the alternative is nothing, people aren't going to complain until the alternative's actually replacing me.
Yeah, and as we have yet to deport, 12 million people, a lot of whom work in healthcare, but we might be doing, that. The Trump administration may or may not be doing that, in the next 6 to 9 months. We'll have to see how that plays out. And I think that harkens back to something else that Michael said, right, which is that a lot of this depends on what else is happening. And I think if you have, some really radical things going on outside of healthcare in the Trump administration, I mean, if they really do come after politically come after a bunch of people they say they're going to prosecute and come after the freedom of the press and, do all this revenge stuff we heard about and go after the mass deportations, which apparently is what base of the Republican Party voted for, you may find that this stuff doesn't get up there in the conversation anymore, and we kind of forget we had this, and we'll be talking about, can you get laborers in nursing homes anymore because they've all been sent back to Guatemala or wherever. Anyway, Shantanu, let's end with you. What do you think is an interesting thing that perhaps we haven't talked about, or what else is exciting? What do you
Yeah, I mean, I think something that it's been slow and a steady drumbeat, but I think it's going to continue to accelerate is consumer demand for change. And I think that's part of what we're seeing with what happened with UHG. I think it's what you're seeing with consumers buying like the clean water system that I bought from my girls. And I think you're going to continue to see it in terms of how it drives people's search behavior and sort of behavior around health care seeking. Like we in healthcare are going to continue to do this runaround. And I think I see patients, consumers, families more activated now than I've ever seen in my career. And and I think that's going to be more of a force to reckon with in 25. So that's what I'd add.
Well, I hope for consumer activation of the good type. That is a wrap on THCB gang. Your December, I have December 5th because I didn't update the date on the slide, but it's December 16th edition. You were listening to Michael Millenson from the wilds of Chicago, Shantanu Nundy, who I think is on the East Coast in the DC area, where everything is about to change, and God knows, revolution will be happening in a month's time, but hopefully not an insurrection of lefties invading the capital. Although who knows if January 6th repeats itself. And Beracah Stortvedt from the calm, placid, beautiful climes of San Diego, where it's not raining this today. You've been listening to. I'm Matthew Holt, your host. I'll be back later this week with another podcast starring e-patient Dave, Hugo Campos, and Gilles Friedman, who'll be talking about patients using AI. So that's going to be an unusual one, but later. But that's it for THCB Gang today. Thanks for watching. Thanks for listening, and we will see you soon.